the beat strategy. Hey guys, I want to discuss with you the beat strategy for reducing hospital readmissions for bone marrow transplant patients. Um, so first of all, what is bone marrow transplant? This is a process in which healthy bone marrow is transplanted into a person with weakened bone marrow. This can be achieved through a variety of factors, but generally speaking, my patients have cancer and they get intense chemotherapy that wipes out their bone marrow. Your bone marrow regulates and produces the cells in your body, so you need those red blood cells, white blood cells, and platelets. Those are very important, and without a sufficient bone marrow system, you don't have those. So like I said, blood cancers like leukemia, lymphoma, also melanomas, myelodysplastic syndrome is very common. And kind of a new thing is they're actually curing sickle cell with bone marrow transplants, so that's very cool. Certain immunogenic disorders can cause weakened bone marrow, and chemo and radiation itself damages the bone marrow in a way that it needs to be repaired. So there are certain health risks that come with getting a transplant, and these can be long-lasting. I have a list here, and I'll kind of go over most of them more in depth, but everything except infertility on this list can cause readmissions, which we don't want. So GVHD, or graft versus host disease, this is a very common after effect of bone marrow transplant. Basically, the grafted bone marrow attacks the host's body, and depending on the area it affects, it can cause a variety of symptoms. For example, it can attack the skin, like in this picture, cause that peeling and blistering. It can attack your mouth and cause sores that make it unable for you to eat. It can attack your GI system, eyes, lungs, etc. And certain ones, like the lungs, will require readmission because it's very dangerous to be short of breath. Our hepatic veno-occlusive disease is another side effect from the intense amount of radiation and chemotherapy. It can cause lesions and occlusiveness of the small arteries of the liver, and this can cause liver failure. And you'll see those symptoms in these patients. And in combination with another side effect, organ failure, it can be very deadly, with like an 80% fatality rate when it has organ failure involved. So we call this MODS, or multi-organ dysfunction syndrome. It's caused by a variety of different things, mainly infection, GVHD. Certain medication can be toxic as well. It can be reversible in a lot of situations, but you have to act fast or else it'll start domino affecting and causing more organs to fail. All right, so this is one of the biggest causes for readmission, immunocompromisation. So these patients have low white blood cell counts because of the chemo and the radiation. So until that bone marrow that's transplanted builds up enough, they will be very immunocompromised and at risk for getting sick. So in this picture here, I put RSV because that's actually very common in our transplant patients, and it can be very deadly for them to catch something that usually affects babies. But this is very hard for patients to adjust to because it requires lifestyle changes. Like pets and kids can actually be big causes of infection, so very hard to adjust to. Fever neutropenia can hide itself as an infection, so it's a similar workup to an infection. We would check for cultures and do antibiotics, and this can be fatal if not treated as well. It's a fever with a low neutrophil count, and this affects 80% or more of bone marrow transplant patients. With those platelets being so low, there's also an increased bleeding risk for patients. Things such as brushing your teeth or bumping your arm on something can cause bleeding. Blood thinners can be very deadly for these patients, and falling can cause brain bleed. So any kind of fall, we want to readmit the patient, do some scans, things like that. Of course, with cancer, there's always a risk of relapse, and the highest probability of that is in the first year. So some of the outlooks for relapses are not very optimistic. Blood cancers generally are fairly low on the survival rate. And if a patient did need a secondary transplant, those have even lower success rates. But the relapse is not something we really can control, so I want to focus on the other issues. So symptom related, this would be something like nausea causing someone to want to be readmitted to get that better under control. So commonly we see nausea or pain. All right, so all that was just to explain that these people are very vulnerable health-wise. They're discharged into the world, and if they don't keep up with their visits or their education, they can be remitted pretty soon, sometimes within a few days after the transplant. And socioeconomic issues can cause issues with coming to follow-up visits, so that's another burden they have. And with our program, people will need caregivers, so that's another step in the process. So I think it's smart to have a plan here in place that could help educate them no matter how far away they are, because many of our patients are different states, different countries even. So I think a telehealth involved group via some kind of Zoom call, Teams meeting would be helpful for these patients. So I've created this BEAT, bone marrow transplant education and admission reduction team. So through this, we will educate patients continuously from the comfort of their own home. And how this would work, we would recruit patients when they get discharged. The nurse discharging them could give them information about this and get them to join it. And I would say this is primary prevention because we are counting the readmit as the disease per se. So they haven't gotten the disease that caused them to be readmitted, so they'd be primary prevention. Secondary would be them going to a follow-up visit and getting a scan to determine if they need to be readmitted or not, or some kind of lab. And the tertiary would be the treatment they would receive when they're readmitted. So with this being said, we're focused on education and prevention factors. I think having a good team together with a doctor, nurse, transplant coordinator, maybe a social worker would be great. Have them on the call with the people and getting them the answers they need. I think weekly meetings would be great, and the time would be dependent on the cohort that people that are close together in transplant dates. We could focus on the main important topics, the biggest risk, infection, diet, hygiene, symptoms to report, and follow-up visits. We also want to provide resources for our patients, so support groups, caregiver information, and even transport services. That'd be the role of the social worker in a way. So measurable data. What do we want to measure here? So I think we want to get the amount of readmissions of the base population and compare that to the readmissions of our BEAT group. And we want to kind of block out those readmissions that are not necessarily preventable, like the relapse of cancer. We also could measure follow-up adherence for those patients and see if they're actually coming to those meetings, and that's improving their follow-up adherence in the doctor's office. We also could check attendance in our program and see if we lose people over time or the other way around. And we could survey the audience and see if they like what we're doing or if there's anything we need to change about it. So the first competency for the advanced practice nurse be communication. That's the main thing here because educating is communication. We need nurses that understand how to communicate well with patients and explain difficult topics in a way that's understandable. So I recommend that these people be BMT CN certified. That's a certification that better prepares them to explain and educate on these issues. Proper communication will actually improve the outcomes of these patients so they'll be able to understand the education itself. And number two, critical thinking and reflective thinking skills. So critical thinking is very important no matter what you do. It's just thinking outside of the box and understanding that every patient is different. So we need to evaluate that on a different scale for each patient. And we can reflect on what we did right and did wrong with this BEAT team. So here's my references for that, and I hope you guys enjoyed it.